Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 388 of our pharmacotherapy series, which majors in seizure disorders. The next clinical case reads, RHO, a 19-year-old, 64-kilogram young woman, has experienced simple partial seizures, complex partial seizures, and secondarily generalized tonic-clonic seizures for the past 2 years. She could not tolerate treatment with phenytoin, that is severe gingival hyperplasia and mental dullness, or valproate, that is hair loss, tremor, and a weight gain of 8 kilograms. In addition, neither phenytoin nor valproate was dramatically effective in reducing her seizures. She currently receives carbamazepine 600 mg 3 times daily. For the past 3 months, while being treated with carbamazepine, she has had approximately 5 simple partial seizures, 3 complex partial seizures, and 1 generalized tonic-clonic seizure. This represents an approximate 30% reduction in her frequency of seizures. She tolerates her present dose of carbamazepine but has experienced significant drowsiness, incoordination, and mental confusion at higher doses. So my question to you is, what are possible therapeutic options for RHO? Evaluate the newer anti-epileptic drugs and their possible usefulness for RHO. RHO is exhibiting a partial response to maximally tolerated doses of carbamazepine. An alteration in her current anti-epileptic drug regimen is indicated. She has not tolerated other anti-epileptic drugs because of side effects. Although valproate is effective for control of partial seizures, it is not considered an alternative in a woman of childbearing age. RHO's CNS side effects, e.g., persistent drowsiness, with other anti-epileptic drugs would make many clinicians reluctant to consider medications such as phenobarbital or primidone as either alternatives or adjunctive agents to her current carbamazepine regimen. Use of one of the newer anti-epileptic drugs as adjunctive medication may be of value for RHO. New anti-epileptic drugs marketed in the United States since 1993 for maintenance treatment of epilepsy include the following: eslicarbazepam, ezogabine, felbamate, gabapentin, lacosamide, lamotrigine, levetiracetam, oxcarbazepam, perampanel, pregabalin, tiagabine, topiramate, and zonosamide. Clinical trials for new anti-epileptic drugs are most often carried out in patients with partial seizures refractory to standard anti-epileptic drugs. Most of these newer or second-generation anti-epileptic drugs were initially FDA approved as add-on or adjunctive treatment in patients with partial seizures with or without secondary generalization. Also, consensus is that some of these anti-epileptic drugs may be effective as broad-spectrum agents. For example, lamotrigine appears to be a useful treatment in absence seizures. Most of them are less sedating than older medications such as phenobarbital or phenytoin. The most common side effects seen in the clinical trials with eslicarbazepam were ataxia, blurred and double vision, dizziness, fatigue, headache, nausea, somnolence, tremor, vertigo, and vomiting. Gabapentin and tiagabane have not been associated with serious side effects. Gabapentin can cause weight gain and tiagabane can cause nonspecific dizziness relatively frequently. Common adverse effects associated with lacosamide include dizziness, headache, diplopia, and nausea. Gradual escalation to the desired dose reduces the adverse event risk. The most serious adverse effect associated with lamotrigine is skin rash. Rashes occur in approximately 10% of treated patients, usually in the first 8 weeks. Rashes leading to hospitalization occurred in 1 of 300 adults and 1 of 100 children. Widespread, maculopapular rashes usually appear and may progress to erythema multiforme or toxic epidermal necrolysis. Lamotrigine-related rashes may resolve rapidly when lamotrigine is discontinued. Co-administration of valproate with lamotrigine may increase the likelihood of dermatologic reactions. It is partly for this reason that more conservative dosage titration and lower maintenance doses of lamotrigine are recommended for patients receiving concomitant valproate. Higher starting doses and more rapid dose escalation than those recommended by the manufacturer also increase the risk of skin rash. Levetiracetam is generally well tolerated, with the most common adverse events in clinical trials being asthenia, vertigo, flu syndrome, headache, rhinitis, and somnolence. The most serious adverse effects are behavioral and are more common in patients with a history of behavioral problems. Levetiracetam should be used with caution in patients with a history of suicidal ideations. Oxcarbazepine, a keto derivative of carbamazepine, is essentially a prodrug for the monohydroxy active metabolite. Oxcarbazepine probably causes less frequent, less severe adverse effects compared with carbamazepine, with the exception of hyponatremia. Hyponatremia is more common with oxcarbazepine than with carbamazepine. Baseline and periodic serum sodium monitoring is indicated during oxcarbazepine therapy. The most commonly reported side effects of oxcarbazepine in clinical trials include ataxia, dizziness, fatigue, nausea, somnolence, and diplopia. Adverse effects of pregabalin are dose-dependent and usually occur within the first 2 weeks of treatment. Somnolence, dizziness, and ataxia are most common. Pregabalin also appears to be associated with a dose-related weight gain. Topiramate can cause cognitive disturbances, lethargy, and impaired mental concentration when given in large daily doses, especially in combination with other anti-epileptic drugs, or when the dosage is titrated too aggressively. Topiramate has caused nephrolithiasis in approximately 1.5% of treated patients. This adverse effect is believed to be related to inhibition of carbonic anhydrase by topiramate, with resulting increased urinary pH and decreased citrate excretion. Topiramate can also cause acute, secondary angle closure glaucoma, which presents within the first month of therapy. Topiramate is associated with weight loss. Zonisamide is a sulfonamide derivative and thus is contraindicated in patients allergic to sulfonamides. The most commonly reported adverse events include ataxia, somnolence, agitation, and anorexia. Kidney stones have developed in 3% to 4% of patients, some of whom had a family history of nephrolithiasis. We will now shift gears to their pharmacokinetics. The newer anti-epileptic drugs have somewhat different pharmacokinetic profiles from those of older agents. They also differ in their tendency to interact with other anti-epileptic drugs. Gabapentin is excreted entirely by the kidneys as unchanged drug and is not significantly bound to plasma protein. Gabapentin has a relatively short half-life and should be administered 3 times daily. Lacosamide is excreted mostly by the kidneys. Dosage reductions are warranted for patients with renal impairment, that is a creatinine clearance below 30 ml per minute. It is less than 15% bound to plasma protein, has a 12 to 13-hour half-life, and is administered twice daily. Lamotrigine is primarily eliminated by hepatic glucuronidation and excretion of metabolites in the urine. Other anti-epileptic drugs, such as carbamazepine and phenytoin, induce the hepatic metabolism of lamotrigine. When lamotrigine is co-administered with enzyme-inducing drugs, its half-life decreases from approximately 24 to 15 hours. Valproate inhibits lamotrigine metabolism, causing increases in half-life and serum concentrations. Patients treated with both lamotrigine and carbamazepine may experience more nausea, drowsiness, and ataxia. It appears likely that this interaction represents a pharmacodynamic interaction between lamotrigine and carbamazepine. Levetiracetam has a short half-life and is eliminated primarily by renal mechanisms. Dosage reductions are warranted for patients with renal impairment, that is a creatinine clearance below 80 ml per minute. The drug has a low potential for interactions with other drugs. Both eslicarbazepine acetate and oxcarbazepine are prodrugs. They cause less hepatic enzyme induction than carbamazepine and may therefore be less likely to interact with other medications. Both, however, increase the metabolism of oral contraceptive hormones. Because eslicarbazepine and oxcarbazepine have similar mechanisms of action to that of carbamazepine, it is unlikely that either would offer significant benefits to RHO because she has not responded to maximal tolerated doses of carbamazepine. Pregabalin is excreted entirely by the kidneys as unchanged drug and is not significantly bound to serum proteins. Unlike gabapentin, which requires more frequent dosing, pregabalin can be administered 2 or 3 times daily. Tiagabine has a relatively short half-life, that is 4 to 7 hours. It should be administered at least twice daily. Concurrently administered enzyme-inducing anti-epileptic drugs may reduce the half-life of tiagabine to 2 to 3 hours and necessitate use of larger daily doses and, possibly, shorter dosing intervals. Tiagabine is highly protein-bound, that is 96%. And it is displaced from protein binding sites by valproate, salicylate, and naproxen. The clinical significance of these protein binding interactions is unknown. Topiramate has a half-life of approximately 20 hours, which allows twice daily administration. It is only partially excreted by hepatic metabolism. Approximately 70% of the drug is excreted unchanged by the kidneys. Topiramate is minimally protein-bound, that is approximately 10% to 15%. When topiramate is co-administered with enzyme-inducing agents, topiramate clearance is increased. This interaction may necessitate titration to somewhat higher doses when topiramate is used with enzyme-inducing drugs. Zonisamide has a long half-life and low protein binding. It is eliminated by both hepatic metabolism and renal excretion. The average half-life of zonisamide is 63 hours, but there is wide interpatient variation. Serum levels of zonisamide are reduced by enzyme-inducing anti-epileptic drugs, but clinical consequences of pharmacokinetic interactions with zonisamide are rare. On the basis of efficacy and side effect characteristics, gabapentin, lacosamide, lamotrigine, levetiracetam, pregabalin, tiagabane, topiramate, or zonisamide could be considered for use as adjunctive therapy for RHO in young, active patients such as RHO. Sedation might prove to be a problem. However, it is not clear that any of these drugs predictably causes more initial or long-term sedation. The short half-lives of gabapentin and tiagabane and the associated need for RHO to take several doses during the day might decrease her adherence. Therefore, lacosamide, lamotrigine, levetiracetam, pregabalin, topiramate, or zonisamide would be reasonable choices on the basis of convenience. Because the patient is not tolerating carbamazepine, it does not make sense to switch to either eslicarbazepine or oxcarbazepine. The reason that ezogabine, felbamate, and perampanel are not good options for RHO at this point. Ezogabine and perampanel are very new to the market and both have FDA-boxed warnings, vision problems and behavioral reactions, respectively. Felbamate's usefulness is seriously limited by its association with aplastic anemia and hepatic failure. Let's now consider potential therapies. Other anti-epileptic drugs that may become available in the near future include brivaracetam, ganaxolone, and huperzine. These drugs may become useful as alternatives or adjuncts to established and newer medications in the future. With advancing technology and knowledge about genes and brain networks, future treatment strategies should move from controlling symptoms of epilepsy with anti-epileptic drugs to prevention and cure. For anti-epileptic drug-resistant epilepsy, much research is examining the role of multidrug transporters, e.g., P-glycoprotein, at the blood-brain barrier. These proteins may act as a defense mechanism by limiting the accumulation of anti-epileptic drug in the brain. Although it has not yet had much of an impact on the clinical care of patients with epilepsy, pharmacogenetics of anti-epileptic drug therapy is continually advancing. RHO is to be started on lamotrigine as adjunctive therapy to her carbamazepine. I would like you to outline a treatment plan for initiating and monitoring therapy for RHO. What should RHO and her family be told about this medication and how to use it? Lamotrigine therapy should be initiated in RHO with a slow upward dosage titration to minimize early sedative effects and reduce the likelihood of skin rash. An initial dosage of 50 mg per day given at bedtime is recommended. The daily dose can be increased by 50 mg every 1 to 2 weeks. Because RHO is currently receiving carbamazepine, induction of liver enzymes is likely to increase her dosage requirements for lamotrigine and allow a less conservative dosage titration. A twice-daily schedule is recommended for maintenance therapy. Usual maintenance dosages of lamotrigine are approximately 300 to 500 mg per day. A patient's ability to tolerate this medication ultimately determines dosage limitations. Onset of side effects, e.g., nausea, diplopia, ataxia, and dizziness, may prevent further dosage increases. RHO should be told that she may feel drowsy and possibly experience headache and upset stomach, but that these side effects usually disappear with ongoing therapy. She should contact her physician or other health care professional if severe side effects occur that make it difficult to take the medication. This is especially important if she exhibits a rash. 2 days after her dosage of lamotrigine was increased to 300 mg per day, 12 weeks after beginning therapy, RHO noticed that her vision was blurring. She also complained of feeling dizzy and having difficulty maintaining her balance. Previously, she had experienced only mild, occasional nausea. She had continued to experience seizures at approximately the same frequency she had before the initiation of lamotrigine. Her physician had encouraged her to continue taking the medication and explained that it would take time to increase the dose to possibly effective levels. Her current carbamazepine serum concentration is essentially unchanged when compared with when she was taking it in monotherapy. So my question to you reads, do these new side effects represent treatment failure with lamotrigine? If not, how might these new side effects be managed? RHO's side effects may limit further dosage increases. Her current side effects might represent carbamazepine intoxication, lamotrigine side effects, or an interaction between these two medications. Because RHO tolerated the same carbamazepine dose previously, carbamazepine intoxication seems a less likely cause. Assessing the role of lamotrigine as the only cause is difficult. Obtaining a lamotrigine serum concentration to aid in assessing her adverse effects is not likely to be helpful. A usual, therapeutic range for lamotrigine serum concentrations has not been established. Clinical studies have failed to demonstrate a significant correlation between lamotrigine serum concentrations and either therapeutic or adverse responses. Her symptoms may also be related to an apparent pharmacodynamic interaction between lamotrigine and carbamazepine. The effects experienced by some patients taking both drugs may be relieved by reducing the carbamazepine dosage. RHO's carbamazepine dosage was reduced from 1,800 mg per day to 1,400 mg per day. After 5 days, her side effects persisted and her seizure frequency appeared to be increasing. The clinician decides to abandon lamotrigine therapy and institute treatment with levetiracetam. I would like you to recommend a plan for initiating RHO's levetiracetam treatment. RHO previously tolerated and had a better therapeutic response to a higher carbamazepine dose. Therefore, the dosage of carbamazepine should be returned to 1,800 mg per day before levetiracetam therapy is initiated. Little specific information is available to help determine how lamotrigine can be safely discontinued. As a general rule, rapid discontinuation of anti-epileptic drugs is not recommended in other than emergency situations. Therefore, immediate reduction of RHO's lamotrigine dosage to 200 mg per day would seem reasonable. This dosage could then be reduced by 50 to 100 mg every week until lamotrigine is discontinued. Levetiracetam treatment should be instituted immediately for RHO because of her continuing seizures. Levetiracetam does not interact with other anti-epileptic drug. Therefore, discontinuing lamotrigine during initiation of levetiracetam should not create difficulties in assessing RHO's response. Levetiracetam should be initiated at a dosage of 250 to 500 mg 2 times daily. Although the manufacturer recommends initiating treatment at 500 mg twice daily, patients may better tolerate lower initial doses and more gradual titration. RHO's daily levetiracetam dose can be increased by 500 to 1000 mg every 2 or 3 weeks, according to her tolerance of side effects and her change in seizure frequency. Although the drug reaches steady state quickly, allowing at least 2 weeks for observation before dosage increases may improve patient tolerability and allow for a more thorough evaluation of therapeutic response. At present, the relationship between serum concentrations of levetiracetam and therapeutic response or symptoms of intoxication is not well defined. Therefore, RHO's dose should be titrated to the maximal tolerated amount required to control her seizures. In controlled trials, no clear benefits were apparent at doses greater than 3000 mg per day. Regarding patient education, RHO should be informed that with levetiracetam she may experience side effects similar to those she had with lamotrigine. RHO's mood should be assessed at each visit. Much reassurance and encouragement may need to be given along with this information to help ensure that RHO adheres to her treatment regimen. Many patients become discouraged when multiple trials of medication are necessary and side effects are prominent. They may express feelings of being guinea pigs and may become uncooperative with the therapeutic plan. Given that RHO's seizures are still not well controlled, driving restrictions that were likely put into place earlier should be continued. RHO should be counseled not to drive until she is seizure-free and her driving privileges have been reinstated according to applicable state law. This restriction can be very hard for some patients to accept because it can significantly decrease their independence. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arua, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 389.